This is Lacey Wilson reviewing the comprehensive case study for the patient ND, referred for excess fluid volume. The patient is a 78-year-old female who is 62 inches tall and currently weighs 232 pounds with a weight history of 220 pounds, which demonstrates a 12-pound weight gain reported to take place over the past week. This puts her at a BMI of 37 and a classification of morbid obesity. Her food and nutrition-related history was dictated by her healthcare proxy, who is her husband, and he reported that her primary source of nutrition is tube feeding formula via her percutaneous endoscopic gastrostomy tube, or a PEG tube, which is a permanently placed tube to provide fluid, tube feeding formulas, medications, that sort of thing, for a patient who is unable to get enough nutrition PL. The patient's labs show a markedly decreased albumin level, which is indicative of a long-term physiological stressor on the body. The glucose level is also elevated, which can indicate more of an acute injury or disease, infection, physiological stress, that sort of thing. It can also be indicative of an inconsistent nutrition intake, that sort of thing, so it could be due to the tube feed as well. The bun and creatinine levels are elevated, which are indicative of either acute kidney injury or even a longer term, more chronic renal failure issue, and again that would be shown based on consecutive renal lab values that we would need to take. In terms of her relevant conditions, she clearly has edema related to that fluid excess volume, since it is a fluid buildup in the interstitial area of the cells and of the tissue. The hematuria and hematosis are inappropriate blood at sites of the throat and the urinary system. So there's blood in her urine as well as at the site of her tracheostomy. She does have urinary tract infection, and again it should be noted that she has a chronic tracheostomy, which does provide her ventilation and controls her respiration. Pertinent medications, supplements, and herbs. She's on both vitamin K and Coumadin to regulate her and to help with the fact that she has a past and a history with cerebrovascular accidents. The castor oil is to help regulate her GI system. Bumex is the diuretic that's being used and has been used for the fluid retention that she's having, so to pull that fluid off. Equestrin in regards to her cholesterol levels, to help regulate the cholesterol in the blood, so it does work at the bile acid level. Santyl is used for the management of the pressure ulcer that she has, so that works at the microscopic level of the cells within the area that the pressure ulcer has occurred. The Keppra is to help manage any epilepsy, any seizure activity that could be happening or is happening. The Lipressor is in regards to the cardiovascular system, to help regulate that, as well as the KCL, since that's a combination of the electrolytes. Sliding scale insulin in regards to type 2 diabetes, and also just to help regulate the intake of the tube feeds. Again, she does have a pressure ulcer. It's a stage 3 at the coccyx. They are unable to provide vitamin therapy that is called for in the evidence-based research because of a protocol per pharmacy at St. Peter's Health. So because she is on tube feeds, they are not able to open up the tube feed container and open up the vitamin pouch and mix the two of them. Again, that's why she is on the Santyl. Her history is significant, again, for CVAs, the cardiovascular accidents. She's had 2 of them, one in 2007 and one in 2012. The most recent one being the more devastating of the 2 that has left her mostly unresponsive and with the inability to communicate. She also has chronic obstructive pulmonary disease with respiratory failure as well, again highlighted by the chronic tracheostomy for ventilation. And again, she also has type 2 diabetes. The estimated nutritional needs are based on an ideal body weight plus an upper 10% added to that as well, since she is under such physiological stress and she is overweight to the extent of a BMI of 37, so we wouldn't want to too drastically underfeed her in this case. So a calorie range of 25 to 30 calories would bring her to 1,425 to 1,710 calories each day. We'd assess her protein at 1.5 to 2.0 because of the pressure ulcer and the low albumin levels, and then we would again wait to see more consecutive kidney function values to see if there is some sort of chronic kidney disease happening, in which case we would tailor back the protein if she is not on hemodialysis at that point. But for now, a protein level of 1.5 to 2.0, which would bring her to 86 to 114 grams of protein each day. And her fluid, based on a recommendation and order from the MD, to be restricted at 1,200 milliliters due to the excess fluid volume at this time. Her current diet order is NPO because she is on tube feeds, which the formula is Vital 1.2 with the goal rate of 50 milliliters continuous, which she does hit that goal rate each day, with free water flushes at 150 milliliters for 4 hours. So that tube feed provides 1,440 calories, 90 grams of protein, and 973 milliliters of water. And again, an extra 600 milliliters of free water to bring her up to the 1,200 milliliters each day of fluid. She is unable to feed, so she needs extensive and total assistance, and again, she is on the tube feeds. So the healthcare proxy or the nurses take care of that for her. She does have both chewing and swallowing problems because of the stroke that she had this past year. And her intake upon admission is minimal because she was admitted with no tube feeds for the past 6 hours. So a current nutrition diagnosis would be inadequate enteral nutrition related to, again, no tube feeds for the past 6 hours, as evidenced by the absence of tube feed administration. And that was due to the necessity to have her ambulated from her home to the emergency department, in which case they were collecting all of the assessment data. Again, all of the information had to be processed from the healthcare proxy. He was unable to present upon admittance the tube feed formula and the rate that she was on. So again, all of these things together combined for a tube feed break in her tube feeds for 6 hours. So an intervention in regards to this diagnosis would be a nutrition prescription of 1,425 to 1,710 calories each day. Again, the protein at 86 grams to 114 grams, or right around 90 grams of protein each day, and a fluid restriction of 1,200 milliliters each day. The food nutrition should be delivered via tube feeds with the formula Vital 1.2 at a goal rate of 60 milliliters per hour with 25 milliliter flushes every 12 hours. That would work out to be. The tube feed would provide 2,800 calories, 108 grams of protein, and 1,150 milliliters of water, which would then, again, she would need the 100 milliliter free water as well to be added to that formula. In regards to nutrition education, it's not appropriate at this time for the patient due to her inability to communicate and inability to feed herself. The nutrition counseling would be per nursing for the family for home care for the patient, since they are her primary caregivers. They would just need to follow up with any changes that are being made to the tube feeds, and that sort of thing. Coordination of care, of course, nursing, the attending MD, any renal specialists, GI specialists, and pharmacy for the tube feeds. The goals in regards to this intervention and diagnosis would be that the tube feed attains appropriate calories, protein, and fluid needs, and that the patient tolerates the tube feeds. And the indicators that we would monitor and evaluate in regards to the patient's progress toward these goals would be that the tube feed meets energy needs, and again that criteria would be the tube feed is meeting the goal rate, which provides adequate energy, protein, and the fluid restriction. And then also GI function, any residuals, and the lab values as well would need to be monitored and evaluated. So proper GI function, so the absence of diarrhea and vomiting. Residuals, so no residuals or less than 20 milliliters during the tube feeds, and electrolytes and albumin within normal limits, as well as the renal indicators, bun creatinine and GFR within normal limits as well. So this patient will be followed up and cared for inpatient, and again we will follow up in a day or so once the patient is admitted to a floor, and the plan of care is dictated by the attending physician. We will go from there and make changes at that point, and we will continue to track her renal lab values to see if there is a chronic kidney issue going on, in which case again we would need to assess the protein levels, bring them down. The fluid restriction is already there, and we would maybe need to switch her to another formula, or if the attending physician does diagnose a chronic kidney disease or an end-stage disease and recommends hemodialysis, we would then again reassess the protein levels and the fluid levels, and most likely recommend a change in formula to something like Nepro or that sort of thing. So we will follow up and make adjustments at that point. Thank you.